to bring that again. Mitchell, who is the SRO of that operation. Well, I think they're all working with us.
I've had on to my seat. We're going to look at those out pathways through. Thank you.
Perfect, thank you. So good morning, everyone. Those of you who don't know me, my name's Emily Lambert and I'm the Lead Nurse Pathway to Excellence programme here at Northampton General Hospital. And we're really pleased to be presenting to you the story today of our redesignation journey. So you may have recently heard that in July 2023, Northampton was the first hospital in the UK to achieve Pathway to Excellence designation for a second time. And we were only the second hospital in Europe to make this achievement for the second time. So this is a real story of celebration of our nursing teams. When we consider for us that our pathway journey began before COVID and we've had to carry this journey, the teams on the wards have through the challenges of being a clinical nurse with COVID, but also continuing to strive for nursing excellence. This is a real achievement for those teams. Next slide, please. So for us, Pathway to Excellence began back in 2015 and we set off on that journey because as a trust, we had a very high nursing vacancy rate. And what we sought to do was make a difference to our nurses. We recognised that as a profession, we saw lots of nurses leave Northampton because there weren't necessarily the development opportunities for them to thrive here, so they had to move on to other organisations. But also that vacancy rate was very felt by the staff that we did have working here. The Pathway to Excellence is based upon 6 standards, and those are shared decision making, leadership, safety, quality, wellbeing and professional development. And over the rest of this presentation, we're going to share with you some of the highlights of those standards that have really made a difference to our nurses here. I mentioned COVID earlier, but I think for us, what Pathway to Excellence did was post-COVID, it was a real lifeline for us. It gave us an opportunity to give back to the nurses who had given so much to us during a really difficult time. And it really enabled us to have a sense of collective endeavour to go on and thrive and work together as a nursing team. So over the last year, we've spent time gathering evidence. It's around a 500-page portfolio of evidence we submitted to the ANCC. And that was then followed by the nurse survey, which happened in May of this year. Next slide, please. So in May of this year, our nurses took part in the survey. Now, to pass the survey, we had to get 60% of our eligible nurses to take the survey. So that was 1,307 nurses, and we managed to achieve an 83% response rate, which is an amazing achievement. We had to score above 50% agreement. So when you're given a question on the nurse survey, what you're asked to do is strongly disagree with a statement. And for it to count as agreement, you must either agree or strongly agree. And we had to score above 50% agreement on every question, which we did. But we're also really proud that in terms of the trajectory of meeting the 21 out of 28 questions being above 75%, that we scored that on all 28 questions, with 11 of those questions actually scoring above 95% agreement. So that's 95% of our nurses agreed that we had created that positive practice environment which Pathway to Excellence seeks to create. Next slide, please. So for us, what have we seen the benefits? For us, what started as a nursing initiative at Northampton has really grown to include the whole MDT. This year, we've been chosen to be a case study for NHS England because they've seen that actually this has grown beyond nursing across the whole MDT, and we've been particularly highlighted as a story of success for that. I think it's also been about finding our champions. Pathway to Excellence really enables us to talent manage within the organisation. We find nurses, AHPs who are really destined for great things, and the programme gives them a sense of a pathway, really, so to speak, of setting off that leadership journey and being able to flourish at Northampton. I think it's fair to say that the programme has its translational challenges, and one of the things we'll often talk about is that we often get asked about is that the programme is American, but I think what we've proven is that recipe for success doesn't matter whether you're based in America, whether you're based in the Middle East, whether you're in the UK. Actually, those 6 standards are really fundamental in making a difference for our nurses. And I think it's also really you know, operational pressures are always there, but Pathway has given us a framework to continue to focus on our staff and our workforce during those operational challenges. And it's really brought a sense of joy in work. I think during the survey period, what we saw was that when our staff were focused and had that sense of collective endeavour on the wards, our patient experience data improved during that period, which really shows the benefits of our happy staff, our happy patients. So before I hand over to my colleagues to tell you about some of the standards and the amazing work they've done, I just want to share that our future plans are for us to continue to look at this as we're currently leading in this in the UK, and think about our maternity services and what that may look like. So I'm now going to hand over to Stephanie to tell you about her experience of being a shared decision-making chair. Next slide, please.
Thank you. Morning, everybody. My name is Stephanie Dale Valentet. I am an associate practice development nurse here in NGH, and I'm currently the chairman of the International Shared Decision-Making Council. I'm actually the fourth chair of the council now, because we have started this council around 2019. Every year we rotate to develop leaders. So the International Shared Decision-Making Council is a group of international nurses, and we focus on the well-being of our international staff. Okay, and what I can tell you about my experience is being in the council has greatly developed me personally and professionally as a leader. Because as we know, as the shared decision making is having that voice, and collective voice just grows bigger and bigger and bigger, and we are getting heard. And some of the projects I can share to you is we've done our first Cultural Awareness Day last year, and we've had huge positive feedback about that. And that's why we have just recently concluded the second Cultural Awareness Day just 2 weeks ago, and we're planning to do this annually now. Again, it's for well-being and to value our staff really. Next slide, please. So yeah, so these are just some examples of how we meet as leaders. We do leadership council meetings, and yeah, so we talk about how we can share projects, actually share ideas, share our best practices, and yeah, influence others. Next slide, please. Yeah, this just shows you how the council has grown. It involves multi-professionals, you know, from HCAs to domestics. Anybody can lead the council. So it just shows you how SDL can grow people. Yeah, I think that's all. Thank you. And I hand over to my colleague Anna to share about her story about being a director of nursing.
Hello, good morning. So my name's Anna. I'm one of the junior assistants on Talbot Butler, but I'm also one of the Director of Nursing Fellows this year. Within that, we have a few more nurses, a midwife and an AHP. So I think for me, the Director of Nursing Fellowship has really helped enable me as a leader. I was fortunate enough before this to have a junior sister post anyway, but was very new into it. And this has helped me grow as a leader to support my team, but actually help them grow as well. I think that the Director of Nursing Fellowship is great for people because it's helped across the board of Pathway with well-being, quality, safety, and we've been able to improve our area as a result of it. Next slide, please. So within this, we get to do the RCN leadership project where we all work on either a quality improvement or a service improvement. So for me, I'm looking at how we manage nausea and vomiting post-chemotherapy in our cancer patients. It's something that we're able to do on the ward. It's our speciality, but sometimes our patients have to go through A&E, and there has been delays in them receiving treatment between trying to communicate between teams, which naturally with struggles can be easy to do, but there's a patient at the end of it. So for all of us, our projects are either looking at enhancing how staff wellbeing can be maintained or actually patient safety. So yeah, I will have. That's all.
Hi everyone, I'm Holly from Infection Control. I don't know who's doing the slides. Thank you. I have the privilege of being involved in leading the quality standards. I think this was the easiest standard in a way. There's so much amazing work that we do across nursing in Northampton. It was a real privilege to pick some of those brilliant pieces of work and share them for Pathway. It was really, really good to be able to showcase work that the smoking cessation team have done, the patient experience team, their family and patient-centred care. I can't remember some of the other examples off the top of my head. The work that the infection prevention team have done, implementing CPE, national guidance, all sorts of things. And it really was the easiest standard, I think, because there's just so much great work going on out there every day, and so much care and compassion, and quality of care being given. And I think it's really nice to have been able to see that and showcase it and shout about it for Pathway to Excellence. Next slide, please. In particular, I'm sure some of you have heard about the FIT accounts that we had, of course, the Infection Prevention and Control and the Viability Council. We do a lot of work together, so you'll find that we're seeing the same patients on the wards. Same patients are at risk of getting an infection as they are of falling, as they are developing a pressure ulcer. So we really came together, and Pathway enabled us to do that and give us a shared voice. So we do a lot of collaborative work together to reduce those harms to patients. I hope really successfully. At the moment, we're having a big focus on continence care and preventing catheters, preventing upper pressure ulcers. And we're doing a lot of piece of work across the whole system around this. So it's a really good piece of work that we're doing. Next slide, please, Richard. And another output that we've had that's really improved the quality of care by protecting patients, particularly from CPE, a bug that's spread by contact precautions, is our BPP3 campaign. We did it last summer as part of the Green Team competition. I think Stuart was on the judging panel for it already. The success from this project, it's blown me away. It's absolutely blown me away. We've presented nationally and internationally on this work. It's won a few sustainability awards. NHS England, the Midlands, loved it and scaled it up to the Take Your Gloves Off campaign for the whole of the Midlands. And last week, the Chief Nursing Officer's Office for Wales, they want to roll it out across the whole of Wales. So we're really delighted to have done something really productive, really sustainable, really that's improved the quality of care through that, preventing patients for infections. And it just shows the opportunities that Pathway give you to do your best and, yeah. Thank you. Next slide, please. Why did I put this on here? You put this on here. Around Miss May came really just to well, I mean, really, when we celebrated Pathway with our matrons and our nurses that all came to the boardroom for the day. It's a lovely celebration. I think just to say that although we did really with Pathway and with the quality standard, we know that quality is, as you guys know, you can always improve more with that journey, quality, always improving continuously. And there's still so much more to do. So we can't wait really for the next 4 years and to see what brilliant examples from practice we'll be showcasing in our next Pathway submission, which will be here before we know it, I'm sure. Thank you.
Next slide, please.
So I'm Sophie, I'm the lead professional nurse advocate for the Trust. So I'm just going to talk to you a little bit about how the professional nurse advocate role supported the wellbeing standard. So next slide, please. So the professional nurse advocate role is a new role that was introduced in nursing from our Chief Nursing Officer for England, Dame Ruth May, in 2021, and it was piloted in critical care, and my background is critical care, so I was fortunate enough to be trained in the first cohort of professional nurse advocate training. So it is a 10-week course that is at master's level, and it just trains nurses for holding restorative conversations with staff, supporting quality improvement, and supporting career conversations, so really looking at retention and wellbeing of our staff. So we had 3 critical care staffs that were trained in the first cohort in March 2021, so during COVID, and I was really fortunate enough to be given the opportunity to be the lead PNA for 1 day a week from April 22, and that was increased to November to 2 days a week. So what we've had is we've been really fortunate to work with our senior leadership nursing team, and we have projected time for our PNAs, so 7.5 hours a month for all of our PNAs across the organisation
provide that like restorative sessions for the staff. So we formally launched our service in July of 2022. So as you can see here, the nice picture of we went around the board promoting the role to the staff because, like I said, it was a new role in nursing, so we wanted to promote it. But what's really important, it isn't just for nurses, although it's only nurses that can qualify to do the role. We support all areas of the multidisciplinary team. And actually, we've been really fortunate in partnering with our AHP colleagues to look at training some AHPs in professional advocacy as well. So next slide, please. So we now have 30 qualified PNAs across the trust, which is really, really great. And we've got an extra 14 expression of interest for the next cohort. And we've got 12 staff that are actually on their PNA training at the moment. So nationally, our target is to reach 1 PNA for every 20 members of nursing staff by 2025. We're well on our way to meet our target of 80 PNAs trained over the next couple of years. We've developed a steering group, which we're now merging into a shared governance group, actually, which we meet quarterly to have that strategic overview of our service, but most importantly, to provide supervision to our PNAs. Is what we want to do is we want to make sure that we look after our PNAs and support their wellbeing as well. We're developing and sharing new ideas both regionally and nationally, and we're actually looking into the system-wide now to create that sort of structure to look at sustainability of the role. And actually, we're presenting about the NGH journey at the Pathway to Excellence conference next week in Chicago. So that's really great to really show how we've implemented the role and the impacts that it has. So we're continuing to review data metrics, but just looking at the impact of the role is that we're seeing in areas where we've provided restorative sessions with staff. We've noted actually the turnover has significantly reduced. In one area, it's actually halved their turnover rate. And we've also seen a reduction in short-term sickness in the areas that we've supported as well, which has been really, really good. And we've recently celebrated our first PNA birthday, which we had in the boardroom. And we celebrated our success by inviting all of our PNAs and wider team to celebrate the success of the PNA service so far. Next slide, please. So just to show, just since April 22, we've held over 500 restorative sessions across the organisation, and we've held nearly 300 career conversations, and we've supported 42 quality improvement projects over the trust. We've also held restorative sessions across ward areas, which actually is really nice that Lorraine and Heidi attend to have that really direct link with some of the ward areas, and hold open question and answer sessions with them as well. So as you can see there, 100% of the staff who have attended them so far will access the PNA again. 98% found the day beneficial, and 97% said they would like these days again. So overall, a real success in seeing, and actually what we've also mapped is looking at friends and family tests following these. So from one area, we saw that their average significantly increased, and directly after the restorative days increased to 100%. So we really felt that actually that really showed that if staff were happy and listened to it well, they would provide better patient care. So I think that's it. Thank you. And back over to Emily, please.
So for us, creating a positive practice environment here at Northampton has been beneficial across the whole of the MDT, but one of the groups we've really seen that have excelled from this is our internationally educated nurses. You just click, because I think something fingers up. Thank you. So for our internationally educated nurses, this year we were awarded the Pastoral Care Quality Award, and our pastoral journey here at NGH for our internationally educated nurses started as a result of the Shared Decision Making Council. And one of the reasons we were able to achieve that accolade so quickly is because we'd already built really good foundations in there. Next slide, please. So I just want to share by really sharing a few stories with you about the difference this has made for both our nurses and our staff. A lot of you probably know Jane, who is on the screen as our Freedom to Speak Up guardian. Jane really, when she talks about this story, celebrates with us that Pathway to Excellence and shared decision making, when she left India and came here without her children, gave her a sense of belonging at the organisation. She was able to link in with peers, and suddenly she felt heard and supported. Jane went on to become the chair of our internationally Educated Nurse Shared Decision Making Council. And that really for her then started a trajectory of becoming a leader within the organisation. And we're really proud of Jane and what she's achieved as a result of that, and continues to support us, encouraging other internationally educated nurses in that way too. Next slide, please. So we did hope to have Helena, the patient on the screen, join us this morning, but I'm not sure where Helena is. So I'm going to improvise and imagine Helena is stood here talking to you. So Helena nominated Frances, the nurse in the middle, for a Daisy Award. And I think this is a really great way to end, just showing the difference this makes to our patients when our nurses are empowered to do a really good job within the organisation. So this is Helena's story. I went to A&E with very low SATs. I was struggling to breathe and my asthma was not stabilised. I was referred to the asthma clinical nurse, and that's where I met Frances. Frances reviewed me thoroughly and discussed the main history of my asthma. She spent time and energy ensuring I had the right medication, a pulse oximeter, and most importantly, reassured me I would be okay. Frances contacted me daily for 2 weeks, checking I was following the care plan she made for me. She spoke not only to me, but to my husband and daughter, and ensured that we were all aware of the risks, what to look out for, but most importantly, that we were all okay. Since August 22, I have had 13 A&E admissions due to my asthma, and Frances has followed me up after each one the next day, diligently checking in and making a plan for my care and ensuring I'm never alone. Frances has given me confidence and reassurance. She's helped to make sure my asthma is not impacting on me physically and emotionally. Her reassurance and kindness and care helps me to understand the side effects of the steroids and makes me believe that everything will be okay. Most importantly, Frances has reminded me that I am still me. Even when I don't have an appointment or a query, I'm able to call Frances to clarify queries and concerns. Frances has worked with a range of professionals across the MDT to coordinate my care and ensure that I receive excellent care at all times. She makes sure communication is effective, that I'm kept in the loop. Frances is a truly person-centred care nurse. She goes above and beyond. She has helped me on this journey of recovery with my asthma, and she's helped to give me back my life and a new way of living with this condition. Thank you. I'm happy to take any questions.
Thank you. A comment and a question, if I may, please. So, first of all, we congratulated everybody in our last board meeting, but it's a fantastic achievement. So, I have to say it again. And it's award to board achievement. So I'd like to thank Heidi for her exceptional leadership in making sure that we got accredited and we engaged everybody. Narelle came into the organisation, how long have you been responsibility So Narelle really stepped up, and we also have a great medical champion with Amand. So it's been a real joint effort, hasn't it, between senior leadership and staff on the board. So that was the comment, and congratulations. The question is, you touched on the multidisciplinary team aspect, Emily. How are we going to do even more of that next time?
So I think in terms of the parameters of the survey at the end, those are very fixed, and we will continue to work with the ANCC. But I think one of the real strengths we've had over the last year is that last year I was able to conduct a piece of research with the other NHS organisations that looked at collective themes of Pathway to Excellence, and what came out of that is other organisations also evidencing and supporting the benefits of this for the MDT. So I guess it's the fact we're going to continue to grow these standards aren't isolated as being a good thing for nurses. I think if you pick them up and put them in any work setting, in healthcare, out of healthcare, that they would be really important. So I think it's continuing to work with our AHP colleagues, really inspiring them to have a voice through shared decision making. As I think we know in nursing, that was the real catalyst for change, but also the other initiatives that we run, such as the Director of Nursing Fellows. We're one of the first organisations to pilot that in AHPs, and we know that's going really well. So I think it's just about continuing to grow what we offer within nursing to include the wider team.
Huge congratulations, and I'm sure you've heard lots of praising for your work, and I'm happy to join this chorus. I still remember going around and seeing these fantastic billboards, encouraging people to participate in survey. So I'm really looking forward for the next accreditation to see how more engaging work you ladies will be leading. My question is triggered by the information about 42 quality improvement projects. It's amazing. Could I ask you which ones you're the most proud of?
I think the most proud one is probably looking at self-rostering. So we are trying to implement self-rostering across the organisation with support of highly young players, which has been absolutely phenomenal, really. So we trialled it in critical care, and we've extended that to 2 other areas of the trust, so on Anna's ward actually. I think that the feedback we've had from the self-rostering has been phenomenal because it gives people their work-life balance. So actually, again, on one of the boards in particular, you'll see a reduction in their short-term sickness. So I'm hoping that with some increased resource potentially in an area that we might have to look at implementing in other areas of the trust. So I think that's the one that we're most proud of.
And comment on Kill's as well. So I remember when this started, was it 2019?
We got the first accreditation in 2018.
I remember that starting. It's amazing to see such an achievement. It's still to have so much energy behind it. Because so often we start these things, it goes with a big bang, and then something else comes along. So it's such an achievement just to do that. And the scores, the nursing responses on the survey were brilliant. They were really, really good. Question: is there still room in your programme to do some mistakes for facilities? So whether it's for your fellowship or something else, there's lots that our teams do, the nursing teams, food always springs to mind. Is there room in your future plans for us to do something together?
Yes, absolutely. So one of the key things we want to look at over the next year is how we develop our model of shared governance. So looking not just at having the isolated councils in ward areas, but also learning from the FIT Council and thinking how can we bring multi-professional groups of staff together to make decisions on really key themed areas. So things like sustainability, and we're working with Ramandeep to launch a digital council, but absolutely, I think that would be a great collaborative and we'd be really happy to support.
Thanks. Hi, Emily. Yeah, the response rates on your survey is really, really impressive. We'll need to capture that. Probably with the staff survey running at the moment. So that's the capture. My question really was, how more as a board can we support you for the great work you're doing?
So I guess really continuing to champion this within the organisation. I think for us, we know that this is just the beginning of the journey we want to go on. We really want to see this grow and expand. And I think one of the things that makes Northampton really special, as Jill touched upon, is that board level support. So I think it's just to say thank you, because that hasn't gone unnoticed by us, but also by NHS. That's been a really different thing here, but just to ask for your support in continuing to value this and celebrate it across the organisation, and really to connect with those frontline staff, because I think that's where it's hugely meaningful to them and makes a difference.
So I guess I just wanted to pull out some of the, when the ANCC came over, you have to acknowledge the hard work of the team representing factors they were concerned about in terms of whether we would be successful. Is the change in leadership, because they recognise that where there's change in leadership, they don't necessarily see the same success rate. So whilst Joe referred to it in a way of coming in and just making a decision to go earlier was, it was not an easy decision. And I acknowledge I pushed the team quite hard on that decision, but I guess it's really acknowledging your leadership too. Naraya was phenomenal coming in, but the bedrock that you set around this being really meaningful, and going forward, how you're really embedding it, because I think this isn't about doing it every 4 years, this is about embedding it in the way we do things around here and within the organisation. And I'm seeing those wider impacts on our financial position, improvement tied to some of the work Becky's team's doing, etc., really feeding in much more than it did when I first came, than it not just being a nursing initiative. So some of the things that are staged to actually, I went to the PLA session this week, I can't remember the day, things are getting older, I think, but we talked about some of the estates things and things linked to the quality aspect, also linked to how we tie in the state. So and the flexible working, people's risk appetite is changing in terms of that ambition. So a huge thank you for your leadership, all of you, because you've been pretty phenomenal in that bedrock. But now what we need to do is make sure it becomes what we do, so it isn't such a task to prepare for the next submission. It's just the way we do things, and we could resubmit at any point. And finally, I have to acknowledge Jill's support. Her support is phenomenal, isn't it?
It's pretty rigorous, but that's what we need, and we're hugely grateful for that. So yeah, so well done everybody. It's a huge achievement.
Thank you. And just to echo that, thank you, Jill. I'm looking alongside Sophie to be presenting at the ANCC conference next week about top tips for other organisations going on the journey. And one of my points is find yourself a Jill, because I think each organisation has been massively supportive. So thank you, because we really appreciate it.
I think it's really inspiration. Two things. I think the way you're looking at policy, I think it's really good. At the end of the day, that's so I think that's really encouraging. I just got a question. The story of the patient is quite interesting. How much of the work with primary care now from the community side? Really, the support of people like that is critically dependent on a more aligned role across the hospital and community care and primary care. I was wondering where we are in terms of some of those discussions.
So at the moment, there hasn't been a kind of a system-wide approach to the excellence frameworks within the the UK. But one of the things we're doing is working with the ICB to look at how we can collaborate that nurse and excellence piece across the region, but also particularly in Northamptonshire, if there's a real opportunity to grow some of that shared governance that we've talked about there as well.
Yeah, so just on that, Victor, I should have mentioned that actually Ollie's done a piece of work across the system, PC work, care homes, etc. So some of the work that Perform is recognised through Pathway to Excellence, Yvonne's been a huge support and think about how we can strengthen that across the system.
That's really good. Much. Thank you. Minutes of the previous meeting on the 27th of July. Any comments on that, Wilson? Okay, there's no. Any comments?
Yeah, thank you.
Any questions? Thank you. Just a couple of comments from me then. Nearly 100 days since I started. I'm live. And I think, we've seen some really good progress here about that. So exciting getting started with it. There's been a lot of discussion on collaboration. I think it's not quite exactly fine. And that's sign off. Actually, really looking forward to actually setting about later. And I think that there's some real opportunities. Definitely on the boards, we're out to advertise for some social events, and also after today, we'll be going out to invite applications for across the trusts. Again, we're trying to have many conversations involved across the collaboration, so that's really so there's a lot to do, but I think this is one of the opportunities. Ask them. So, something just a couple of things on the agenda. There are two items particularly for me. That you know, the council suggested was an investigation of some information. That means very strongly to speak up. I think that freedom to speak up is really in terms of this particular staff and in terms of this misinformation. So I've been really keen on that. I think it's important. We really need to support. And those two items really come together. So I'm really about these things that with this good cultural in terms of some of the lessons that come out of it. I hope we're going to hear some really good stuff, but I think we've got a responsibility to also set that culture and we also be looking at it already. I think we're also so ask ourselves how do we step up. NHS. So I just wanted to highlight those two items. Okay. I'm happy to take any questions. Surely there aren't any.
I would take my report obviously as read as normal, and there's a few things I would like to put out, and obviously the accountant suggest is one of those. I think it's really important to stay our thoughts to collective and with those families. And as John rightly says, there's some very obvious learning without knowing the full facts coming out of the inquiry. So some of those for me, I think there's the obvious freedom to speak up, which I'll come on to a little bit. But some of that is about how we lead as a board, as an executive team, how we go about doing our work, and really engaging with the organisation and with our patients. So I think that's a slight nuance of the culture work, but really important that we think about that specifically. Obviously, there's the angles of Insta reporting, encouraging Insta reporting for things in terms of misses, not just where there's significant more serious incidents, etc. And equally, how me and Helen have discussed some of the things around the clinical pathways. Are we confident that some of the unusual results, for example, picked up in a timely way? Some of our learning desk works here, which Helen will come on to later in the paper, has been incredibly strong. So I'm pleased to say in all of these areas, since I've been in post, the executive team in post, we've spent a lot of effort, as Jill will know, on a number of these areas, and please from a freedom to speak up perspective. As John said, this brings it into really sharp focus around the importance of rigour, breadth and depth from a number of angles, and looking at intelligence in a different way, which is something we're also looking at in terms of our PSA and patient safety journey here at the Trust. So there's a number of angles that it triggers for me. All of them, I'm pleased to say, are areas that we're on a journey to improve, but it does bring a more poignant light, along with other national reviews such as East Kent, some of the mental health aspects, the Manchester case, for example. They all have considered learning across them, is what I would say. So, so on the freedom to speak up, as you know, when I first came, we didn't have a designated freedom to speak up guardian. I'm pleased to say that's a much stronger support to our teams, but we are looking at how we can take that forward even more. And with Sanjeev, our new freedom to speak up guardian, we're really fortunate her background in levelling up, working with global majority colleagues here at NGH really adds a different perspective to freedom to speak up and a real strength for us. So we're still working on that at the moment. As you'll see in the report, one thing I do really want to put out, as some of you will know, when I came, I didn't feel we had a really strong engagement strategy with colleagues across the Trust, and we implemented Connect, Explore, Improve, which is really aiming to engender a culture not only of listening and people being psychologically safe and speaking up, but having an environment for people to raise ideas, feel curious, feel empowered to raise their voice in a positive and where they might have concerns. But also to explore that together, so to really drive the accountability. This isn't an organisation where we want people to be passing things up, for example, and feeling that it's so hierarchical and they can't drive things forward themselves. So exploring together and improving together, so it's a collective responsibility. So some of our cultural work has really tried to engender that collective responsibility that we've just heard on Pathway to Excellence, for example. So we've been on that journey, but I'm pleased to say in the last month we've had what we call the Big Connect. I did say we'd call it the Big Connect, but I wasn't actually being serious, but it did end up being called the Big Connect, where there was an ask. It's fair to say different parts of the organisation embraced it more than others. We've used it in maternity with really successful outcome, for example, where we had areas where we knew there was challenge when I first came. But in September, all of the teams have been asked to create Connect sessions to explore and improve with their teams in all areas of the organisation. So everybody's had the opportunity to be part of a Connect session. We've done it within teams, within divisions, but we've also done it across staff groups like admin and clerical, which we've done together, plus consultant colleagues, junior doctors in training, etc. So international nurses. So we've done it, we've cut it in different ways to make sure everybody's had a voice in September and had the opportunity to join. As you know, we do one every Thursday, executive colleagues lead it, and anybody can join that one. And the feedback from some of the people who weren't quite as energised by this kind of thing, it's fair to say, have fed back that they found it really empowering and learned things about their teams that they probably would never have learned because they weren't having that conversation. So hopefully that assures the board that wider psychological safety tied to freedom to speak up and the wider culture that John's referred to is something that we've started a journey on, but we've still got a long way to go. But there's absolute commitment on the exec team. Also, what I wanted to pull out, it's really important as part of the Council of Chester that patient voice is really strengthened. So through Pathway, we've done quite a lot of work. We've done quite a lot of work for our patient experience team with certain patient groups, but also we've implemented a call for concern in the organisation. So if there is anybody who feels something doesn't feel right, there's an initiative that's already in place, which obviously is tied to Martha's rule coming in. So what we will be doing in terms of next steps, we've already started an executive team and we'll be linking with non-executive colleagues soon to look at this in a much broader sense across a number of national reviews ahead of the inquiry to ask the question, could this have happened here a couple of years ago? Could this have happened here based on what we know a number of years ago, and do we think it would happen now? So that really helps us understand our journey and where we think our success may or may not have been, and have some really honest conversations about that. I think there's been some really good work done by people to keep delving and keep making sure we're assured in these areas. We'll also look to learn from colleagues across Leicester and KGH along the journey to make sure, so we've already connected on how we're learning from the counties of Chester across the team. So yeah, hopefully that gives you insight into some of the work we're doing. Also, assessment accreditation is tying into that as well. So moving on in my report, I won't go into planning because I'll be covering that on the agenda, so I can go in there if needed. Important to say strikes obviously are continuing. I can't thank our teams enough, Hemmings and the LNC, for their support. But obviously it is taking its toll on our teams in terms of the relentless kind of strikes that continue. But I can't express the kind of collaboration that we're seeing. Some of my colleagues across the country have said they're starting to feel some tensions within teams. We haven't really found that at all, but we do have to acknowledge that it's not easy for them. But pleased to see that positive perspective continuing. As you can see from the report, we've won some more, or been acknowledged. We've got some more CNO awards for our HCAs this time. And maternity hub's been open, which everybody will be very pleased about, particularly Jill. And we've won an award for our preceptorship work, which partly is tied to Pathway. But I did want to put out two things. Victoria Summers has been nominated for a Pride of Britain Award. She's done a lot of work for cancer patients and fundraising as an individual, so she's been recognised regionally and nationally, and just to acknowledge the hard work for the robotic team for doing an event for our community to come and really understand what robotic strategy meant for our patients and our community, and that's a really successful event. And finally, the work across East Midlands acute providers, some really positive collaboration at scale, which obviously Richard is it's really positive for us as a trust to engage in that as well as the collaboration across the trust. So yeah, I'll stop there.
Thank you. And thank you, Heidi, for spending so much time in your report and your briefing about speak up about the potential cultural changes we live here. I think the speak up function is really the function for people to reserve when nothing is working. So listening, following up, very important. So sorry to say that bluntly. And your sessions, connect, explore, are incredibly important. I would like us as the board to change ourselves. Do we have sufficient prominence for listening and following up in our governance system? For example, we have to speak up month. Is it enough now? Do we have listening? Do we have follow-up? And actually, listening that is probably very important because most of the cases For the maximum of 9 cases based on staff in terms of concerns and so the possible improvements have to be addressed by the environment officials. And that encourage environment officials, but empowering nurses. They were incredible results. So we'd like to change this. We have sufficient funds and wisdom.
So really good challenge, Elena. So as you will probably expect, me and the people speak up Guardian and Denise may want to come in and Tracy and worked with me really closely on this, speak about this quite a lot. That's the premise of Connect Explore, the green version alluded to, in terms of, in an ideal world, you would need to speak up. I think it would be a bit naive to expect that we would never need it. So I think we'll always have that, but what we're trying to do alongside that is create environments where that accountability for line managers to do listening up and following up. So the bit we're trying to strengthen now much more is the following up. So people see that there is a positive consequence of them speaking up, of them raising ideas, raising concerns, and that it's a real culture of empowerment with consequence. So yeah, it's really, I'll take that idea away in terms of, do we have a follow-up month? No, we don't. We probably do it continuously, but do we approach that in a slightly different way? So the big Connect has really tried to focus on that. Okay, what's the consequence? How do we pull some of this together? So I'm looking back here in terms of how can we be much more transparent on a system so that everybody can see what's been raised, what we're working on, see what each other are working on, so it's not so clunky. That's something that me and Becky have spoken about for some time, and it would be great actually if we could see that across the 3 hospitals, for example, so that teams could collaborate together with something that a challenge to learn from each other. So we're also, off the back of the staff survey, going to create a shared decision-making capital to hold us to account for the results of the staff survey, for example, so that they can see a consequence to them speaking up through the staff survey effectively. So there's still more we can do. I'll take that away as a really good idea, but hopefully you can see we're trying to create that culture where it's part of our day-to-day. In terms of the governance, yes, I've asked that this is an agenda item that is given as much prominence as financial viability, quality, safety, etc. Because if we don't get this right, we won't get the other things right. So trying to shift that mindset in governance and patient safety with everyone is really important.
Obviously, Councillor Chester, obviously very well on the news, etc. We've already heard the issue going on in Blackpool last night with regards to workstations, stroke patients, etc. And it's that learning. I think it was really positive actually. There was a junior nurse that came forward on that one to be nice to our office. So I'll be picking up those elements and learning from those witnesses. So answers Councillor Chester.
Yeah, so that's kind of what I'm referring to. It's really good comment. That's what I'm referring to in terms of, whilst Lucy Lappy is incredibly sad and, you know, is incredibly hard-hitting personally and as a member, you know, as a really proud member of the NHS. There are other reviews, incidents that actually have similar themes. I mean, you can argue that the Francis report has some of this in, you know, there are themes that come across a number of them. So that's one piece of work we're doing, is trying to meet all of it and saying, what does this tell us about our organisation and are we doing the right things in a slightly different angle, so to challenge ourselves. But yeah, I think would we be confident that a nurse would speak up? I think pathways are really positive part of that. Connect is us getting out and about and encouraging people and talking about that not only is we want them to, it's actually their responsibility to give each other and their patients up. So really trying to draw on both angles, not just, but we need to create psychological safety, but actually that shared accountability and responsibility thing.
Yes, thank you. I just wanted to follow up on some of what I was saying before in response to Elaine's delivery from a freedom speaker. I really like that listener as well, and I think because we have been over the last few months, we have been kind of going around and around on how do we. There's a lot of what's going on in the background, the very nature of some of the things that are raised through freedom speaker and some of the work comes to the back of it is obviously confidential. So it's how do we, without breaking confidentiality, how do we demonstrate that we do
things about some of the issues that are being raised. So I think that if we can follow some of that, listen up, follow up, and badge things in that way, then I think that will really help us. So it is something that we're grappling with and that we are aware of, because you need to be, it's not just about doing things about the issues that are raised. We have to, as a board, as an executive, we have to be seen to be doing things, but we have to be doing them in confidence. So that's kind of the balance that we've got to working through, but definitely take that forward on this side.
One thing we need to do this board is we've had quite a bit of change in people is collectively now do the training in terms of this. We certainly change the too late collectively to prepare something together. But yeah, no, really good. With something to do.
What a message. Anyone trying to help you, help find it. We'll do what's going to try and we can find it. So, obviously, she made all the effort to come here. It's really, so, we're not she relies on it. Right, shall we move then on to we have to start with this.
Yeah, okay. So I'll go straight into the concerns, most of the things we'll talk about if you comment. So I'll go straight to brief clinical quality and safety performance. So I'll hand to Andre. You there, Andre? I'll hand straight to you.
Thank you. There are two meetings that the Group Clinical Quality Safety Committee we want to report. One was on the 25th of August, which was not present at, and next one, 29th of October. So I'm going to pass over to Jill to report on the points from the 25th of August, and now pick up from the September meeting.
Thank you. So I'm just going to pick up on a couple of points, if I may, from the templates. So first of all, we always talk about the areas where we have limited assurance. And you can see that at the time, we still had concerns about the integrated governance report due to the absent data and the use of aggregates. So, but since then, we have seen an action plan for the team, which has given us reasonable assurance. And the team was the absent data. And we also talked about potentially putting a caveat, particularly in public board, at the beginning of the IGR to explain that an aggregate, so for example, an average across the hospital, we have 5,000 staff, doesn't tell you the detail. So the detail have to be done into the divisions. So, and what is that effect? So I think although there was limited assurance at the time, the picture has improved. The next thing I just wanted to pick up was we're still waiting for GROW2 implementation in the maternity unit. And as you know, I've mentioned this a number of times at the board meetings. And just to remind the board, this is an app whereby there's an electronic way of measuring the size of the baby. Because if you have those that are small for dates babies, or small gestation baby, they are 7 times more likely to be stillborn. So we need to be very vigilant in identifying those small babies. GROW2 will help us with that. We are getting closer to get to the implementation. It's now on the date roadmap to complete in December, but we are very much looking sooner than that. So we're continuing to monitor that and escalate it where possible. We also continue to be concerned about midwifery staffing levels, particularly in the maternity unit, which covers both midwives and obstetricians. But we gave that reasonable assurance because there are a lot of plans to mitigate that. And also, the initial steps is basically to improve. Happy to answer any other questions.
Any questions on the report? Okay, thank you. Shall we pause that? Sorry. Yeah, I'd like to go to quality. Later work.
You have actually voted in September.
Let's finish off the quality. We'll
I hope we can finish on because there is a point that we need to discuss. So very happy to progress in efforts on it. So in September, which we had last Friday, so we had substantial assurance about a couple of points. One, we heard a story about patients with learning disability. So there are opportunities to share best practices in learning, to support patients, especially outside of specialist working hours. And also we had substantial assurance for the rigorous process elections for it. But there is an additional note that perhaps additional focus could be had with regard to the utility of EPR for research purposes, which may be of relevance to the academic agenda, which we'll talk about in a minute. We also had reasonable assurance from the subgroup exception reports, which were detailed and noted. The action points required, also reasonable reassurance with regard to the upcoming NHS impact self-assessment. Jill has already talked about midwifery and obstetrics staff issues, which will continue to be discussed, and also digital issues and NG for growth to have assurance. Also, we had reasonable assurance to discuss patient safety reports, urgent emergency care, and direct nursing exception reports, but we've concerns about C. diff and other infections, but noting the work relating to falls with harm. So the one thing that you notice in the template, which is a big red block, is the lack of assurance. The group committee did not feel that we could have any assurance with regard to the group academic experience. I was concerned about tentative personnel change, scheme, and also lack of a positive steer towards the progression of both research and teaching agendas. It is perhaps time sensitive because there is the annual report from BRC expected. The BRC started in December 2022, so this is the time for the annual report. So I think we do need to communicate the progress or lack of in that report. And also the other time issue is perhaps an opportunity, because the Office for Students, as we know, public health is intended to increase student numbers, medical student numbers, to 15,000 by 1.2. This number is they expand funding for an additional 25 students for 24-25, and have sent letters to all medical schools for invitation of intended numbers. And there's a deadline, which is the 17th of October, 11 days from today. So that's perhaps an opportunity for the board to consider the position and whether the board is intending to reevaluate indicate that.
This what we came up with the NGH. Sorry, KGH. So, if you want to make some comments on that.
Thank you. I think the points are absolutely valid, and I think the academic strategy which we have marked on for the last 3 years. Currently, middle of October, will be taking a stock take from the financial strategy perspective, with close linking with the University of Leicester's leadership. And I think we're absolutely committed towards further progress with some concrete proposals of a satellite school, which we have been in discussion and getting a project plan around it. In addition to that, from the research perspective, there are also links around, and we have to admit that in the planned appointments of the academic professors has not gone as per plan because of various reasons. So then we need to take a stock of it and have a different approach towards that. We're absolutely committed, myself and John, and we are closely linking with Andrew. Thank you.
I think we need to get some outside this. Finally, this is what we're sorry. Things from the advantage of getting other hospitals 20 years ago, the last time students. That's very huge. So I think it's
Thank you. I'm still in the theme of listening now. And in the quality committee metrics, we have patient satisfaction score. We have a very good score for everybody in NGH. 100% satisfaction. Great. I'm wondering, we're serving thousands of and correct me if I'm wrong, but the average response rate across NGS is hardly 10%. So do we have statistically serious pool of patients saying us that we are that they're satisfied with our services to be? So yes, aren't we misled by the ratio of the response? Yeah, that's probably it.
I want to come back to that. Shall I finish off the discussion on the research, on the academic strategy, then we'll come back to this. I think, yeah, just think outside of this, we need to sit down very quickly and say, are we really going to put some behind this? Like get go back to the work, because there are the opportunities here for research or able staff. But the quality of care, they're huge. I think we will
Yes, so just really briefly, I think we have to acknowledge that this was some of our other strategy was really ambitious about the quality of care and focusing. We did, and I think we need to effectively acknowledge that. And there's been quite a lot of leadership change. So whilst Helen's now in that seat, I'm confident Helen's giving it the right focus. And taking, but obviously it's picked up more recently and the leadership changes and that's actually who's leading on this. So it's one of the things I'm keen to link up with Richard about, and now he's joined us, and I know that Helen is linked with Richard as well, because that strength we've had our ability to recruit and therefore take this to the next level. Equally, I'm confident on great that there's been a lot more robust conversations around how we would accommodate the increased numbers coming through, both from a medical and nursing perspective, actually. So I joined a call from a nursing perspective recently. So I think we need to take the conversation out to do it justice. But I think we do have to acknowledge that the ambition, again, that the strategy was incredibly high, but probably didn't get the focus it needed, and therefore need to reset in line with the opportunities that we've got.
You mentioned other jobs. I don't want us to get investment in this container. So I think the three chief execs and the investors and investors sit down. Sorry, please, Richard. As you say, what do we need to put in place to make sure that this intention and the support and the provide really needs. Sorry, Lenny, can we go back to your, I mean, I think you asked a really good question. Which essentially is, how much does these higher level because you look at wider surveys of population, the satisfaction with the NHS is around like 30%. If you look at the surveys that individual organisations do, question in my mind is how much of that is, which of those is actually the price of the King's Fund? 37%. Actually, that the NHS. So I think your point of challenge, what people much more most of this satisfaction, and I think the challenge was one that I actually wants us some of these firms really tell us.
If the response rate is so low,
The rate,
Yeah, and then I would mention the response rates. So as much as we promote the patient satisfaction, we also promote getting more. So on average, for 8 patients, our response rate is 99% of expected response. So there's no many campaign of many responded. Our easy areas have slightly low, we have 30% of response rate in terms of volume. So then when we push for patient satisfaction, we look at how many responded and what was the response. And in addition to that, areas where they have low responded, we do listening events, like focused listening events, where we invite patients to come in, and then that then captures a wider audience, which is more face-to-face.
same thing exactly.
Okay. I think that's really helpful. I think where I'd like to leave this to need to nominate is I think we should do some work. I've already mentioned focus for trying to keep patient experience. I think what we really important is good quality committee to actually look at this and say, how do we really understand the patients?
Is it just to add one thing? Obviously, Sam was just arrived, so we spoke very briefly in the corridor. As part of the NGH Board, we are looking at how we can do that digitally with patients, because friends and family testing is not intuitive necessarily here. And so we're looking at how we can do it in some particular areas, but also how we can have QR codes and forms of crowdsourcing around this. So I've spoken to Dan, our Director of Digital, about it, and briefly caught Sam in the corridor the other day. So I think that's something we can do to make it quite intuitive and even more instant response for us to feed into the wider intelligence that I discussed earlier. So the cultural work is looking at that as well, that we have in terms of how we engage with the community much more proactively, not just waiting for them to come into the hospital.
So there's some thinking already, but I think we need to have an approach about it. I think we really understand what patients experience. What is something very island stuff? I'm not sure it's hugely helpful. Sometimes you have to get much more details to really understand. So how we really like it. But I think that's a fair challenge. Just a slide. What does somebody work with? Really tell us about things. I'm going to we'll move into the quality section. Really important points to raise this. Can I welcome? Sorry to make you wait a bit longer. Anyway, thank you very much.
It's a crazy system out there. I got here and then I left my reading glasses at home, so I had to find the number for Emily, and then went back to the chest clinic and got Francis, who was in clinic, the receptionist, to ring her to tell her where I was. And I go here. That was a real Irish way of going around, wasn't it? I found my way through the system. Found some doors that I'd never been through before. I didn't want to go through them. Thank you for even asking me. Sit down or stand up. Why? It's just I want to hold you up anymore. So my name's Henry, and came into A&E, let's say about 18 months ago. And it seems like a very long time ago, but been in and out a few times more. Within the 18 months before I wrote this letter to you, it was 11 times, but it's gone since then. I had some really bad insurance, and obviously I had COVID, and then I had a cold, but I'd never been identified as being negative with, positive, should I say, with COVID. So I just put it as a bad cold. It continued. I kept getting chest infection after chest infection. We couldn't go to the GP, so I managed a lot of it myself at home. And they would send you some antibiotics and talk to you on video calls. That went on for quite a few months, but I didn't realise the impact was getting more and more until I crashed, which happened to be just before Christmas time, when my son was severe asthmatic. So I've grown up with asthma in my family. I kept feeling the tightening in my chest and feeling it getting worse, and I thought I'd get through Christmas, and then unfortunately, when my stats hit so low, I can't remember what they were on a piece of paper, but at one stage they were like 32% when oxygen levels when I got into the A&E. I felt I was having a heart attack. They pulled me through. They did lots of tests with me, lots of tubes coming out with me, lots of oxygen going on. And it was really scary. And I had this wonderful consultant who came over and talked about me, talked about what was going on and what was happening in my life, and was there any stress factors that was going in. And I didn't have anything in particular. I just told him how I was managing my symptoms. And from there, he referred me to Francis in the chest clinic, which I'd never been to before. And neither had my son growing up in Northampton. I had a lot of allergies, they did the tests and still have allergies with the twins. But lots of tests were taking place there. And I was put on different medication and I was brought in and Francis got to know me as a person and got to know about my work and my patterns and how I was coping with it. I go on holiday and I crash again. I couldn't work out what was the environmental issues that was taking place in my life. So I had to become very aware of where I went and what I did. And I work in the childcare sector and children in care. So children who are bouncing all over the place, and in particular children with autism, it didn't faze me. So I knew my levels and I knew myself, but I couldn't understand why I kept dipping. So more tests were done. Francis would keep track of me. And on this particular occasion, I again went up to the scale. And Francis, I got in touch with her and said, I don't know whether I'm okay or not okay. She says, come in. So I didn't have an appointment. I had a phone number that I could ring and get that help and support from. So for having that with the chest clinic really empowered me to be able to get back out and live my life. That was a huge part for me. And knowing that if I did, I was able to describe what those symptoms were. So therefore they would go and have a look at other tests. The allergy test brought up certain things that I know I'm allergic to, but we live in a world where we don't know where other things can impact you. Like when I went to Devon, they were spraying the fields. So it took Francis to go and make a phone call way out of the country to ring and find out where I was there anything in particular, to come back and say, maybe you're allergic to this kind of tree that's down there. I was blown away by this. And it told me then I had to take more of my inhaler or maybe 2 of the antihistamines that were this new antihistamine, which was just like a magic pill to me, because all of a sudden I didn't have all this ball of fur in my mouth and the roof of my helped me immensely. Francis not only contacted me when I was ill, she contacted my husband obviously to check that I was doing what I should do. I'd be sent off with a doctor, a box which had home care to take my sats, and I found a lot of information from that. When I didn't answer their call, they would ring home, but then I found a glitch in the system. They wouldn't speak to my husband or speak to my children if I was struggling because they didn't have the GPR or have it. So that's gone through now where I've spoke to them and they're going to say, there's a problem there. Why is it you can't speak? When I can't speak, we found that it was easier to text. Likewise with Francis, I found ways of communicating in a different way when everything was too much, too hard, too difficult. Linking these people together, Francis then sent me off to Leicestershire, Glenfield Hospital, where I'm still under these guys now. I found that really hard because I was going out to meet new consultants and saying the same information again, which we've already got in Northampton, and I went through the same tests again, which we'd already got in Northampton. So I found some of that a bit frustrating and a bit like, why are you asking me to do the same when we've already done this here? So I asked the consultants to start talking to you guys here as well. And Francis was really pleased about that because that showed that we've done the job. Why are we duplicating it and sending you all weeks and that's when, you know, sometimes I don't have transport and it takes me 2 hours to get there on the bus. But I'm still under Glenfield. They're still talking closely there and talking about the steroid injection now, whether that's going to help me give me more quality of life. But that's very expensive and I do understand that. But what I have to say above all is having my experience here in Northampton and knowing that I've got somebody there who will not just speak to me, but bring my daughter or my 2 sons. And if they don't get an answer from one of us, they will make sure that I've checked in, I'm okay, and I'm on the right pathway. And I can't thank you guys enough for having me, because I don't think I would have known about doing the things I do right now if I didn't have that wraparound care, as I call it, in allowing me to feel confident in my ability and know that the nurses, right down to the admin staff, knowing your name, know who you are, and welcome you, even when you're having a bad day. So if I'm not on a good day, I can make that call and provisions put in place so I don't end up back in A&E. It takes me away from having to go through all of that, I tell a story when you're not able to tell the story and it's really difficult. And you have so many allergies and you're feeling so poorly and you just feeling off the scale. I have a recipe pack now. I've been taught and I've learned to tune into myself and my body and understand the signs and the signals so it doesn't take me to that place. And it shortens the going back there. I understand I peak and I understand I go down very quickly. I just have to remember not to get to that height. So I drop. So I do get about it. So I have a great network of people and you guys have a great network of people and you communicate so effectively with one another. And when I hear people who are sitting in and I do hear them and I do go in, sit and take some fruit and sit there and I go, you know, why don't you tell them this? Why don't you say all that? Oh, I don't want to bother them. I want to pass all of that now. There's no such thing as not being able to bother them. The nurses have so much experience. And whether it's an elderly patient or a young child who's sat there, I've learned so much. And I think you need people like me sitting in your waiting rooms, reminding them of what good job. And then you get your feedback because I couldn't help but get feedback. I sit in your waiting room while you're sitting there, you're listening, attached there, not getting your feedback. Because my hands would have heard that for days before. I didn't see that poster. I didn't see where it was. It needs to be in our face and and it needs to be given out to us while we're there as to what good job we're doing. Because if we don't come back in and tell you, you're going to hear these stories. And I can't thank the hospital enough for everything to give them my life back.
Thank you very much. I think that was really important with this. You've demonstrated information, working closely, sharing data, sharing information across services in the hospitals. I think that's developing much closer collaboration between hospitals. That's good here. Also, I think primary care. And I think that's the whole purpose of the actually trying to work much closer as a system, much closer collaboration. So I think you absolutely made the case with your experience about where it works, what it means for a patient, and where it's still not working, what it means for a patient.
My doctor wouldn't give me the rescue pack until I argued over the phone. I said, I have used my rescue pack. My sister passed away this July, and I was in Yorkshire at the time, and I took it back to her. My husband brought me my rescue pack, but that was for like a week with the end of. When I needed the second lot, because I wasn't leaving, my job wasn't done to look after, I struggled to get that. But by ringing the asthma clinic and allowing Francis to help me, I would have ended up in your pain because they could see what I was doing.
Absolutely. So I think it's really grateful you came. I think what you've done is told a story which absolutely underpins some of the wider discussions about how we work differently, how we help patients manage their own situation, their advice and support, how we avoid people coming here in emergencies, and how we help people to live a high quality life. And I think your story is absolutely illustrating all of the things that we trust. So thank you very much indeed. Thank you for this. Persevering with our
Good luck to it. Thank you so much. Have a great day. Thank you.
We will go on with the finance.
I bring in Rachel briefly, she'll bring in Tilly.
Yeah, well, that's fine. We will be short and succinct. So I was here for the August Finance and Performance Committee, and probably the topic that I want to bring up is the medical bank rates, which I understand from Helen are now with the ICB, but I would say that we really do need to push to a conclusion to align these costs.
I'm actually going to hand over to Denise now because I was on holiday last day. And I'm sure she will then bring in Richard.
I will indeed. So, yeah, being mindful of the time, there are a number of items that we discussed where we've got separate agenda items today, so I'm not going to talk on those now. We can I think probably that I just wanted to flag up is that we will be talking about which plan. We've put it in on the committee as limited assurance. That's nothing to do with our thoughts on the work that's been done in the hospital. The limited assurance on the basis that actually, as of the time of the committee, there's no national or regional funding to actually enact all the things that have come and got ready to go. So we have no option but that's not our committee. I think that the second thing is around the annual plan efficiencies, and again, some of this is going to come up later in the meeting. But there was a big discussion at the committee around the balance between costs and performance, and quality, and that's, I think that will be an interesting discussion that unfortunately we're having to have. So it was a more serious discussion around the table in terms of focus on quality to the detriment of finance and vice versa. And also that we can talk specifically about the efficiencies that we still have an issue that data provision is key, but in a number of things that we are looking at, people are struggling to get the data, either to get it in the first place or to get really accurate data as well. So that is the thing that has certainly been with us for a number of years now, that we really do need to reach out to stand any chance of managing the financial side of things and efficiency. Those are the key things that I wanted to draw out, so I will hand over to Richard to see if there's anything else that you want to say.
Just a couple of things. So for NGH, it's 11.3 million FC, it's 7 million grants. If the report sets out and that current trajectory, we won't achieve breaking even plan, which we agreed at the start of the year. I think everyone is to be clear on that. As a result of that, we did ask the finance committee to approve a strong cash to support that deficit position, and they recommended that, so bringing that to the board today. So those were the key considered things that we think will be helpful financially for some of the statements.
Any comments or questions? So I understand a bit about where we need to be, etc. So it's the rigor of thinking about what else we can do, try to get to the best possible position. You've just started. Do you feel that there's a real commitment to it's actually doing things up the game?
I think as set out in this wasn't a mistake, we need to demonstrate that really. So we need to demonstrate that we considered all of the options and work through the what those might mean to the organisation. So we have considered that. I think that very much came out in the committee discussion, and people wanting visibility around choices and options.
I think there's a verbal commitment to consider all of that, and I think Richard's absolutely right. We now need to demonstrate that we have been through this and then made those choices. So I think that's absolutely.
So there is absolutely that commitment. I mean, like conscious of time, we can't cover in detail, but I can went to with Mark and others went to obviously some of those bigger scale impacts still need to be across the system in terms of working quite just within the organisation, but we're continually strengthening the rigor within the organisations, as we've discussed many times. So if anyone has anything back in time for that,
No, I don't think so. But yeah, there's work going on within hospitals, and we had a lengthy conversation with the RCB ahead of the board, RCB meeting, executive around how do we start to address the medium-term issues that we need to system.
You know, some of the values that NGH comments are in here, which is that rigor around when the will impact is becoming stronger and stronger and stable today.
But the evidence for addressing this that needs to come back to the board, next board in terms of actually how we can demonstrate the fact that we are looking at everything later, etc.
So moving on to group digital and transformation. You want to add anything?
Given the time, I'll the one area I want to improve about is the while our performance has been really positive across the organisation. Couple of quick headlines: we're currently the best in the country with regards to diagnosis. So we are excellent at telling people they have blood cancer. We still got some challenges to do around treating patients that have blood cancer. That's the really important one. We've hit targets, again, best in region for 2-week cancer rates, so we can see patients quickly. My worry and my concern at the moment is that our waiting list for RTT is continuing to rise. We've gone from 20,000 patients 2 years ago to 40,000 patients. So we've seen a huge increase in referrals, we've seen a 40% increase in ET. That's 2 years. And that whole process of how we manage that to go forward is we're delivering it. We have the lowest number of 2 weeks in the region, but there is a tsunami brewing that we have to work on, and the NGH is the biggest worry area. We are currently outsourcing into in sectors smaller, but it's still better than marketing patients there in the areas we should be examples.
So it seems to be the need to ask we've seen such an increase. You mentioned that we started our waiting times, which is what really likes patients. So I think we need to ask questions on that.
That is a system wide.
I'm conscious of that. Exactly. I think we need to map it out across the system in terms of also reference. Have some equitable discussion around the access for all this activity and have a long-term sustainable solutions as staff to
Yeah, I think that's absolutely. So outside meeting.
So we've just some transformation out and gel and then making this one. Renamed you.
Thank you. There's nothing specific I wanted to highlight to the board. Fortunately, we had some items for information rather than approval because of annual leave and industrial action. We didn't have any executive hospital executive directors bringing the trust, so it was rather sharing information than an opportunity to approve or raise concerns. So, anything you wish to add?
Yeah, if we take all the reports read, given time.
I just think this is an opportunity to go Right, we move on to report.
Thank you. I think the report is read and the thing which I want to fill out, which came across through our discussions with external and internal stakeholders, is that has ability to implement the recommendations from either external or internal auditors. Both T and Brand acknowledge that there is progress and there is lots of grief and the ownership in relation to the actions, but loads of work has to be done during the next 2-3 months period. And we agreed that in the anticipation of the celebration of the completion of many actions, we will invite Heidi to share with us this success. Heidi, welcome to our chamber.
Make sure you can feel the reaction to it.
I understood the
It's Richard Mavad, depending on the project. And over to people committee, so to these people, again, I'll take the paper news thread. I think just a couple of things to note. Firstly, because normally we are looking at things that are concerned, I did want to know that again on the development side of things, we did a substantial showing.
which is great. So the Lead the Way programme, we had a full update on that. So we did pass on that, thanks for that, and it was great to be able to give substantial assurance on that. The key things that surprisingly that we were focused on again is the agency spend. We talk about that in detail at every meeting, and we, it's recognised that we can't, if we carry on doing what we've always been doing, we're not going to change things sufficiently. So there's some different things into planning. So hopefully we will start to see some sign, but we are very focused on that as a community. And it's also good to know that in terms of people KPI performance, that's improving across all areas apart from vacancies. So we are now at a point where turnover and staff absence is starting to decrease. We've had some response rate to the health survey, so that's good. The vacancies is still an issue in both.
So the Quality and Safety Committee referenced earlier to the high level aggregate data in the IGR rather than being able to drill down. For the first time, the committee was able to see mandatory training data and drill down both organisations, both professional group and division this time, and we'll be doing that for other data sets going forward since associations as well. In terms of midwifery, we've also heard this morning about concerns about staffing, and it was really good to see some positive feedback from society colleagues around reducing vacancy, reducing turnover, and a healthy pipeline of new colleagues coming in, both qualified and roles in between now and Christmas. So some encouraging.
The only thing I'd want to add is obviously types of the agency is having got the first process around recruitment, which has obviously been a significant challenge for us. And so there's a transformation project around that, that is just making sure we keep the focus on that because it's inextricably linked to our wider challenge around agency. But pleased to say there's a lot of consultant interviews gone in our diary, which we'll be doing. And that's positive in terms of changing that trajectory. Yeah, that transformation work is crucial to the wider moving forward.
And also just very briefly, just to acknowledge that there has been a lot of work on this to recruit an NGH. We were nowhere where we needed to be. There's been a massive improvement, so we just need to keep it. Thank you.
But thank you for experience. Just questions.
Thanks, Chair. I think bunches of time, lot has been already said. Over the compass of just audit, I think the focus has been on 3 areas. One is staff ability to raise safety concerns, speak up safely. The second is around the robust incident reporting and investigations. And the third is around leadership governance. And most important is reviewing and translating that intelligence to develop a learning culture in the organization. The paper reflects on the 5 domains which have been published by NGH Board to the trusts for introspection and benchmarking against those. We have added a 6th domain to be assurance to the board around the new meeting, the safety culture and morality metrics. We have the first 4 domains as part of our paper of freedom to speak up, guardian and reports. I won't dwell on that in detail. But just to reassure that over the last couple of years, the freedom to speak up guardian dedicated role is embedded. Second thing is October 2020, the new policy came in place nationally. We implemented that. And finally, we internally did a benchmarking of freedom to speak up guardian domains against everywhere. An action plan has been put in place. A lot of work has been ongoing, which has been demonstrated in the paper. To call it all 3 points. One is connect, explore and improve. Meetings where more than 100 people consistently join, and is a place where people can have psychological safety, is developed very well. Then different forums are there as well, for people to speak on. And not only people, the patients, as ideas mentioned, the political concern. I think it's a very important pilot where any member of public who has got a new patient can raise priority to the critical care team. On the fifth domain, which I would like to dwell is around the governance. Obviously, we have embarked on as per the national guidance on a patient safety incident review framework. We have done a significant piece of work restructuring the governance team, secretaries, implementing the piece of, and finally, a lot of medical improvement initiatives because of which shipping currently sits at 88 and HSM is 89. And that's a testimony to the triangulation of the work done from the learning from death groups to get the insights, not only from the deaths, but complaints, etc., related to the governance team. There's a lot of work we still need to do in terms of what is being articulated in the paper, in terms of the engagement strategy, communication, and finally, visibility of the board to make the psychological safety at the forefront for people to raise concerns. I will hand over to Maria to talk about the sixth domain. Questions.
Okay, so the sixth domain is just to give the board assurance on financial purpose. It's a brief summary. There's some attached appendix with some more data in it. So I have broken it down to taking experience, staff experience, and safety culture, and what was accesses and celebrating. So our patient experience is measured through FFT and also through the Mental Voice Partnership, and we have collected the data and our feedback is sent on their experience within the unit, how they feel cared for. This is also correlated with our peer review, which is very patient and very focused in terms of how we give family integrated care. I have put in there about our mortality, MRES dashboard showed up over 5% rather than national average, but that's difficult to triangulate this through lines of death group, which is the event and individual death and their quarterly. Staff experience, I put that in there because one of the things that came out of the Council of Chester was around PNS support within the neonatal unit. It's how we build that resilience on that workforce. So we really centered that work, we're sending to for training, and that will then give us a good ratio of 1 to 20, the trajectory to complete that in the next year. But not only that, one entity working on management unit is very good. So they work collaboratively, even when it's recognition, we do it across the entity with our junior doctors. Again, that came across in our peer review paper, where one of the things they did celebrate was how good our entity working was across the unit, which is a good strength. And that for me is related to that medical and nursing leadership with that, because they work very well together. Safety culture, I would just assume that as read that it's just going to give you assurance on how we give assurance of safety of both the babies and the parents locally, but also across the system and how we work across the network as well. Celebrating success, again, one thing to call out is our good NAP data. Our NAP data across 11 standards shows about 98% above average of our performance. I've put it there for information as well. We've been awarded the Bliss Cross Baby Charter, which just measures how excellent we are in neonatal care. And we've got growth, but we're now starting for silver and gold. But also our commitment to breastfeeding initiatives. So all these things actually demonstrate how we look after our parents and our babies and how we promote that family-related care within our neonatal units. But the best thing to celebrate, which I think I'll thank the board for, is we have completed our new parent accommodation. That has been a long time in the pipeline. But what that means is parents that come out of area, they can actually stay with the babies. So we saw parents come out of areas, but they had to then travel because we had nowhere for them to stay with their babies and co-locate. So we have accommodation now where if they're coming out of area with any other parent, they can remain. And that is something really proud of. Thank the board as well for the report. Any questions?
I just wanted to support you, particularly in relation to some assurance around the neonatal unit. So we have exceptional leadership among the unit, both neonatologists and matron. They are 100% of attendance at our responsibly enabled champion meeting. They present a trust bank dashboard and a regional dashboard, so we are on benchmarking terms. And tragically, we haven't. It's very scrutinised everywhere. So it will go to the incident review group. It may have been serious investigation, serious incident investigation. It's also reviewed by our preventable mortality review team, which is external input. Any serious incident report is reviewed by the ICB. All of our estimates are taken to the LNS. And we also, as Samantha says, look at these through our Learn from Best group. So they are very well scrutinised. So I want to support the amazing work that the team do actually, and continue to support it. And in walkabouts that I have done in the unit over the last few years, talking to parents, I have never had a concern raised, which actually is unusual in terms of other areas I visit, frankly, which is good because I want constructive feedback from our patients and service users. But they all say how fantastic a team are. All the staff say how they love working there, and if you talk to them, you find out how they've worked there 15, 20, 25 years, which I think is good. But there is some turnover as well, so we do have fresh eyes, which of course is also a good thing. So the action of the Lucy let me trial was on Friday. And I know the executive team went in straight away to the unit over the weekend. I went in on Monday, spoke to service users about how they felt about the outcome and what affected they're thinking about their care in the unit. Actually, they weren't bothered. They said our care is absolutely fantastic. I'm trusting the team. But I did urge them, of course, to raise any concerns that they had with the team should they know. So I think we do have a lot of assurances, not that we should ever get complacent. And of course, we want to get even better.
Yeah, so just to say, obviously, we to refer back earlier, we've done this report in response to the NHSE's letter, so it's an initial response. Obviously highlighted the concern from a neonatal perspective too, because that's what just happened. But it's just to remind ourselves this could happen anywhere, and we're looking at it from a trust-wide perspective in the next piece of work. But I concur with the team in and are exceptional on a number of areas in the intelligence. But to assure the board, we did support them from an SOS service perspective, and also our SOS team offers support to anyone across the hospital should they need it as a consequence. And nicely, they offer it to us as an executive in terms of how we make it sphere as an executive. We didn't take it up because we had a really constructive discussion ourselves, but I think the next step is making sure that this from a trustworthy perspective.
Okay, thank you very much for that. Sorry,
Just a very quick question, probably to Nereen, because Nereen was talking about patient experience, and again, the team came across. Do we also use CQC maternity surveys to reach our data? My understanding that CQC runs annual surveys of patients, not only ours, but certainly everybody's maternity patients, and publishes these results in January or February each year. So how does that data translate with what we get through FFT, and what do we do with the learnings from CQC? Not for CQC patients survey.
No, so we have just received our CQC patient survey this last month, and what we do is the patient experience team pull out the learning and sort of do an action plan for each area. So it does triangulate. So for example, the one which is most pertinent is ED, because ED had sort of highlights on sales. So we've taken that and really into through our ED oversight group. So as part of the oversight group, we have the patient experience where you pull out in the line of the CQC patient survey interface. And similar to maternity as well, they get CQC patient survey, and then that is translated through education and feedback reports that we do.
I think it goes back to the earlier, actually through this point, we need to understand approaches to really hearing what honest, I'm not sure that a lot of this is, I'm not sure that many of the current budgets really tell us that. In the level that we need to understand it, so I think the challenge is.
So maybe a dashboard, because there are so many sources of different opportunities for patients to pick up. I think we can create a dashboard for what different surveys, what type of teaching. And that's all stuff recommend and engage places.
Discussion outside this and come back into some recommendation. I'm going to close this down. My last one, then we really must move on because after we finish my course. Well,
So a really quick point. So there's a long history of having maternity risk partnerships, which constitute entirely service users. We have now 420 neonatal voice partnerships. So we have a service user from that group that works directly with the neonatal. So that's just another message.
yes, as I said, we need to across all of us.
Of course, I'm just focusing.
Okay, thank you. Carl.
Chair. Like most organisations, winter planning starts in the summer, it's sort of strange, where we sort of call the team together to look back on what we did last winter, what worked, what didn't work so well, and fixing what we can do for winter cooking. It's fair to say that the winter gets more challenging. And I think this winter has been hampered by the fact that there is no national funding to support it at the moment. Having said that, we know that winter money often comes out from the farm centre very late, but we are teed up ready to go with our shopping list as and when that money comes through. The other thing about this is that absolutely we cannot turn off elective care. That's simply what happens as a knee-jerk reaction when the elective care pressures get too high. And as a result of that, we are doing a full review of the bed stock in the hospital to make sure we've got enough medical beds to meet the requirements. We've only released this recently that 30 to 40 beds short. That will reduce the surgical bed base potentially, but what we are clear about is that there will be beds in those surgical beds. Potentially put barbed wire and sensors on the doors to make sure that we do not go in there under any circumstances. Continue to deliver our key cancer surgery. That's important. The paper which you've got in front of you is split into 3 parts. That's around the external ICS planning, what we're doing internally, and what the individual directorates are doing. Obviously, from an ICS perspective, it's reasonably limited this year, but we are moving to a single point of access for all community and social patients to call for support. I think we also increasingly see, I have board rounds most mornings, patients that have been visiting for social reasons and don't have any real clinical need to be there. And that's a real frustration to see those patients then start to decompensate or try and get social care support to get that. We're very, very good at developing virtual wards. We've got a lot of virtual wards in place, and we'll continue to develop those over the winter period and try to understand patients going through those. And our pathway to, there's a lot of work going on there, pathway to rehab patients and the flow into those units outside of NGH. If we look internally, our frailty is a lot of people excellent, but we've increased the number of beds and it's now running 7 days a week. And our SDEX sees around 90 patients a day, mainly surgical, oncology and medical patients across the board. We'll continue to push that forward in the throws. One thing that really has worked for us is execs and senior managers all adopting the ward, doing ward rounds every single day. So we have no meetings between 9 and 10 o'clock. We've seen a 2-day reduction in length of stay while we were doing that. And I have to say, it has built up phenomenal sort of engagement with the ward teams. So for my wards, you know, I am regularly contacting people during the day for all sorts of things that I can pick up. So that's really how we're going forward. Big focus on antibiotics, the prescribed too long in many cases, and we have seen a reduction in the duration and the numbers of antibiotics being used. And we have done some excellent events over the last 12 months, highlighted by thesis and HSC group. So we'll be doing some more throws and reads out. I think fundamentally that's where we are. There is lots underway. It is hampered by the fact that there's no money at the moment. Our aim is obviously to reduce our emissions and reduce our length of stay. We're certainly focusing on our pathways 0 to 3 from a discharge point of view, because we're already seeing a slowdown of discharges from our social care colleagues, and we're certainly putting that challenge really. Yeah, let's take any further questions.
One question which came up, sorry.
I think it would be helpful, obviously, there's a huge amount of work going on in NGH and across the system. Where does it leave us in terms of that gap and bed occupancy?
So, I mean, based on where we're at the moment, with the plan to reconfigure the beds situation at the moment, we should come in there or thereabouts with these medical beds going forward. But as you say, we have to be there ruthless with the surgical beds that they are not to be able to order.
Yes, a really quick question around this objective impact. I know what impact are we seeing from the early stages?
Yeah, so I mean, since obviously in September, we've had various discharge letters to different parts of the hospital over the years. This is now in the White Hart Hospital function, and we're already seeing earlier flow each morning. So the patient, as soon as it opens up, I said the morning patients move down there, and the PTS crews are starting to move them early, where before we were seeing 11, 12 o'clock.
No.
Consequently, most of the patients were leaving, to be honest, after 5 o'clock in the afternoon.
So we're comfortable.
We are, yeah, absolutely. Still more going, still early days, but there's definitely a shift.
As we've said, a lot of this is system-wide conversations we're having now in terms of what there is no more money, that's what we're working on. And therefore we need to make sure we're working in a really agile way across the system as anything changes based on which funding we've got in place. So the weekly chief execs meeting is concentrating on that. There's a lot of work in pathway 2, for example. Some of the risks that we've seen in previous years in the council, particularly the West, which we didn't have to mention more, is a slowdown in social care. The relationships there are much stronger and the work is much more proactive than it's ever been. So it is incredibly tight, and to Becky's point, I think that bed deficit number is still being worked through in terms of everybody's perspective on that at an ICB level. But some of that is about risk appetite when pressures come in and how that risk appetite is shared across the system, not just within the acutes. Whether that's from an IPC perspective, boarding perspective, etc. We're particularly challenged here because of our estate, it's difficult to board in certain wards. So I guess it's to assure the board we are cognizant there is no more money, there's no intention to be any more money, and therefore we're working on the basis that we need to have significant rigorous system level based on what has happened in the past years.
I mean, it sounds it's good planning. Doesn't really own costs or have a huge bed count. So that was really good. I have not heard any other trust who doesn't have at the same time. That's the big red, which is very like most trusts are talking about. So that's really good. I think Heidi's point about being clear and the relationship. Sam, what it says,
Easy, that's it.
Thank you. I'm going to take 10-minute break. And then we'll move on. And I'm just going to ask people to, what leave reasonable amount of time for people to speak up. Could I ask for people, some of this I know can Right.
Yes, that's for the financial.
So if we come back at 5 past, try and do what previously we had. Okay. Thank you. We are dedicated to excellence.
Super, thanks, Chair. So I've included an update on the review of the dedicated to excellence priorities. If you will remember, in May, we agreed as boards for the updates for the delivery across 23-24, and we had a period of reflection, if you like, around what had worked well and hadn't up until that point. And one of the things that we reflected on is, have we got that real update on a regular basis around delivering, and that have been one of the things that haven't been perhaps particularly strong from when we'd initially agreed in July 2021. So we agreed as part of that we would do a 6-month review on the priorities. So just a very brief update on the process. So 6 months will be in December, so coming back to the December board. That will work quite nicely because it will feed into our 24-25 integrated business planning process, and that which the paper has gone through HMT this month on what that will look like, and also will be really useful in terms of the discussion because we'll be bringing that in after the new framework as well. So that'll tell a nice story around how we are delivering that. Brief reminder of the priorities, so patient and quality overseen by clinical quality, safety and performance, systems and partnerships and sustainability by finance and performance committee, and people committee by people. So in line with that, noting the progress, the KPIs, the benefits, the outcomes that have been delivered against what we said we were going to achieve in these 6 months. Obviously, there are some areas which we have delivered, we've heard about some of those today. There are other areas where we haven't made as much progress. And again, one of the things we picked up when we did the observation is, are we really learning the one thing that didn't go as we expected them to? So we'll be bringing, so we just collated all that information together into a template for discussion with executives in October, which will then go through into HMT and October cycle committee for discussion in the session of committees, and then come back to boards in December.
Any comments on that? Observation? Just one comment which I didn't make at KG was that I think it's our focus of board should be on outcomes. And there's a huge number of projects going on, etc. I think increasingly we should be focusing on the impact it's having and the priorities and the outcomes of discussion. Clearly, in various other committees, some of the processes and how we're doing these components, particularly for some of the differences. I think it's a question of lots of different. So several have an interest in this stuff on board today. And I said the plain statement. Thank you. We speak up annual report. Welcome.
Thank you.
Sorry, we're late.
No.
So I'm delighted to have Jane here as our new freedom speak up guardian. She's going to take the report as well. It's the first time here and highlight some of the ambitions, take questions, and then James brought Brian along, who's sharing his experience of speaking up, which I think as a board we need to acknowledge is really brave and really capturing our value of courage. So thank you both.
Thank you. Good morning, everyone. So I started in April this year, and so I'm going to be a consultation paper is read. So I'm just going to discuss on what the ambitions are for the future and what's happened in the last quarter. So a lot of my focus has been on raising the profile of freedom to speak up, really, and having that visible leadership of the guardian within the trust. That's what something else I'm concentrating on, and also communication, strengthening the communication around freedom to speak up, making sure that staff have the right access to information around freedom to speak up. It's like, from our intranet, we've been creating some posters and also some videos with our chief exec, and as well as including our values ambassadors, making them part of this whole process of bringing that cultural change. Our values ambassadors, they play a vital role. So it's about strengthening their roles and responsibilities within raising the profile of freedom to speak up. And also our strategy is being created, and this is in combined efforts with the values ambassadors as well. And this will be discussed in the people committee session along with some focus piece of work that we had completed following the elected case on where we are. Just to give some assurances on at the back of the NGH recommendation, I think this will be discussed in the people committee. I've also ensured that we have an online feedback form. So the previous ways we were collecting the feedback, just to ensure that there is some anonymous, we can get some anonymous feedback. So we've created an online survey feedback form, as well as included something like the equality monitoring form, so just we get that information more around what are the various backgrounds or staff in various projected characteristics. We just kind of learn where we are in that sphere. And also I've been doing some ad hoc sessions, listening events in focused areas, as well as in ward restoration days, along with our professional nurse advocates. So just to kind of go on towards and make that avenue, create that avenue for staff to be able to speak up within their own areas. Also having regular meeting with our staff networks to kind of relay what the themes are that I'm hearing and to kind of get their input as well in regards to speak up. So some of my ambitions for with me within the role is to address who are the hard to reach groups, to kind of identify who are hard to reach groups. And from National Guardian's Office, we realized that our hard to reach groups are staff from the Black, Asian, and minority ethnic groups, staff without IT access, and our students, AHPs, truly doctors, our international colleagues. So a lot of my focus is going to be on trying to help our staff from our hard to reach groups to come forward to speak to us. And I think I've seen a shift in that pattern since coming into post. I don't know if it's the confidence of staff, given the fact that I'm an international nurse by background, so I don't know if it's improved that confidence in staff to come in terms of them having the confidence that I would have that culture and competency and understanding what their issues are, and if there is any barriers for them to speak up. So we've seen that shift in already. And some of my work is also focusing on staff who are doing unsocial hours. So a lot of our staff who are doing unsocial hours weekends, and also doing night staff, so doing some regular walkabouts to be able to make sure that they also have the right information that they need, and if there are concerns that are pertinent to them, that we pick up on those aspects. I'm fortunate that I've had the October Speaker Month come this right now, so a lot of that launch, to give that new launch and the freedom to speak up, I use this platform as so that we gain that message across. And the theme for this year is breaking barriers, and the Guardian's Office has identified two big barriers, one being fear of staff from their background, heritage, their job position, or the nature of the role. Second thing is the future that nothing will change. So these are the two barriers that they really want us to break. And it correlates with so much of what I said about what my focus is going to be with the staff group. So yeah, we've been encouraging our staff to partake in the campaign. So we had a poetry competition, and a lot of our staff have taken part in that. So it's just that bringing staff to understand freedom to speak up does not have to be like a formal route. It can just improve, it just gives them the confidence to be able to speak up and to be open and honest in their own working environment. So we've been using that campaign very much to kind of promote this. And one of the things that we're looking at in discussion with Heidi as well, we're looking to have a leaders event. I want the focus to shift to the leaders so that the culture picture comes from the top to bottom, and then leaders have the onus, and leaders take up the challenge that they will go back into their teams and promote that safety culture within their own team. So trying to take back to the leaders to understand what is it that the barriers that you will go and discuss with your teams, to understand what the barriers are within their own teams, and how as leaders we could start addressing that, and being the carriers of the culture out of themselves, the leaders, us being the carriers of the culture really. Yeah, and we're also doing a short video of what the positive impact stories are to kind of help staff understand that freedom to speak up is also about bringing improvements, not just concerns, but also saying how it has changed the way they view this whole freedom to speak up service, as well as what are the positive impact it has come for their team or for them as individuals. And so here with me I have Brian, who's come through the freedom to speak up route, and he's just going to share with us of what he thinks his experience was. Over to you, Brian.
Thank you. Good morning. Thank you all for having me here. My name is Brian. working in IT, in our application scheme. It's my 10th year this year in the trust. I'm passionate about what I do. I love my job. I'm also a father of 3 boys, and one is 17, 2 of them are born here. And I'm so grateful to all the staff who have, support and make sure, health boys continue to grow. Eldest has just been in theatre and was looked after really well by colleagues in integrated surgery, which I'm really grateful for. It's through yourselves, the leaders, the decisions you make every day, which make that possible. Last year, I had a concern which I was not sure about or not sure how to navigate. It came at a time where my eldest boy was unfortunate to have been manned in town with knife point. They took away his phone. So I was really scared and everything. Then something else at work was happening the same time, but I wasn't sure where to turn to. And sometimes the easiest way is to quit. I thought I can't manage both things. I may have to concentrate on him, give him emotional support he needs. It's the only care for him. Then there was an advert for the freedom to speak up, the usual one. I would have mentioned encouragement to speak up. I had support from my senior managers, Natasha, one of them, the aspect of different things with transformation without going into detail of the situation. So I approached the Freedom to Speak Up office, and that was escalated to Heidi and made Heidi, and we had a discussion. The meeting with Heidi was quite powerful for me because not only did we just discuss, I felt listened to, but also we connected as parents. We're just talking and sharing similar experiences and guidance with our feeling. And to me, it was quite important being able to communicate with someone at a board level, our chief exec, because normally with our backgrounds, it's not something we would do on a daily basis. Quite nice to do that. The experience was very different with Heidi. She made me feel welcome and joining the connection between yourselves and the board, knowing exactly what's happening on the show floor. For people around my level from my background, it's quite important and very calming. I made a decision from that point that no, I'll continue to serve the community I live in through my work, which I'm passionate about. I will not leave my job. There's no reason to us being asked to leave. I was just overwhelmed at the time. But being able to speak and be heard was quite powerful. So I shared with Jane and I said, she asked if I wanted to share my experience. I was happy to do that. So thank you all for all the job we are doing in leadership, shaping our organization. I'm proud to be part of that family. So that's my experience.
Sorry. Yeah, thank you so much, Brian, because it takes a lot of strength to come and speak about it in the nature that you've gone through and have the strength to come and let us know about what your experience has been. And I'm glad that Heidi and Maya was able to play a part in bringing you to a state where you felt confident that you continue to. Thank you. I've just forgotten to add a couple of points in what I was saying. So one of the strategy that we're trying to say is take it back to the staff to say there are various avenues through which they can speak up. So it could be within their own team meetings, through staff network meetings, and also most importantly, our connected, slow and improved sessions. So trying to bring staff, give them the confidence that they can be openly talking about suggestions for improvement directly to the senior leadership team, and trying to break that barrier between the senior leadership and staff, that staff feel equal, that staff feel that they all have a voice. So we've had a good amount of connect sessions, and we're looking at having these connect sessions towards the hard to reach groups. That's the plans for the future as well. The other thing is ensuring that our training is mandatory for all staff who speak up. At the moment, we're having a market factor, so it could be that we are missing on some staff. So ensuring that we all our staff undergo the speak up training, middle managers undergo speak up and follow up training, and all our senior leadership team and the hospital management team have the chance to go through the speak up, listen up and follow up module. So that is one thing. And we also are looking at having the self-review tool with our combining this from the learning experience director to complete that. So these are three things that I've got really. Thank you.
Yeah, just very briefly, thank you both very much. That was really helpful. Thank you. Just to say that since Jane took our post, the focus has very much been coming back to the point when you weren't in the room that came up earlier about, how do we follow up? It's about speaking up, but then how do we show listening and how do we follow up? I mean, that's the form basis of the conversations that we've been having. So, Jane recognised very early on the biggest task was about kind of breaking down this fear, but also demonstrating to people why it was an important thing to do and how we demonstrate how things changing and what has been done on the back of people speaking up. So we're on a journey with that still, but very much recognise that that's really important to do.
Just wanted to quickly ask about detriment, and it may be something you can't answer, Jane, I don't know, so it's historic. So in the most recent data, I see it's no cases of detriment, which is excellent, but last year there were 11. And so I just wonder what assurance you can give the board around how we are managing that situation to make sure that people can speak up without fear of detriment. So,
yeah, so given, we discussed this quite a bit, haven't we? So on the benchmarking exercise when Ellie left, obviously we've gone from a situation of no freedom to speak up, Guardian independently, and then connected with coming into the organisation, which by all accounts when I came in was a very hierarchical organisation. So it's quite a cultural shift to get people to start speaking up. So we obviously saw a rise, which is positive, but people at that time, and I say more broadly, were not quite clear what the bigger picture and culture really meant. So when I spoke to Ellie about, if you look at what capture detriment can be, that can be really broad in terms of what's classed as detriment as a consequence. And so some of this has been taking our leaders on the journey of not trying to work out who spoke up when an issue came up, or Brian, we discussed about detriment. So it was quite broad. There were no concerning cases within that in terms of severe detriment, but that's something that I've been going to follow. So far this year we haven't had any cases where people have said they've suffered detriment. So we're seeing the journey of speaking up more, taking our leaders on that journey of responsibility, and we don't need to find out who's spoken up, and actually we should actually be encouraging it because you're part of the solution. And I think that's quite powerful. I don't think if we'd have asked somebody to come and speak in the board a year ago that anybody would have felt comfortable coming to speak. So I think the fact Brian's here, I've equally been clearer on boundaries around if there's any detriment and the consequence from that perspective. All it is everybody's responsibility, and that's why Connected is also bringing in the accountability point. So I think we need to keep a really close eye on it, and if there are any kind of consequence of detriment, that's what we're discussing a lot to make sure that if people feel safe to do so, and there's no even subtle detriment. So we really need to focus on that. But yeah, I'm in positive leadership, but we did unpick it quite a bit with them as we went through.
Thank you. Fabulous report. Thank you for the presentation. Thank you for coming to talk to us, Brian. Thank you. My question was about students, actually. So I know we have GMC surveys and we have information from universities. How does that correlate with the themes that are arising from Even to Speak Out, Connect, Staff Survey, etc.? Do we actually put them together to see the themes arising?
No, you haven't like when it coming because Andre did a piece of work around looking at that exact theme.
Yeah, so I think what we have done is we have triangulated the NGH survey along with our GMC survey, along with the themes which are coming. It's a piece of work which is ongoing. That's point one. Point two is I think we definitely have some insights of triangulation now. Where are the focus areas, and then actually the areas where the GMC survey has shown that we need to do more work it's actually coming through the other areas as well. So now we can see the translation.
Another thing I'd add, so actually it's really nice to see that juniors are joining Connected to Flow Improve on a Thursday. So they're feeling part of the organisation. We're talking about it on arrival, and they're raising concerns actually really more courageously than a lot of us groups actually at times. Equally, we meet with the chief registrar, so I met with her last week, just in an intro because she's new, as we're making sure those conversations where we could probably strengthen it a bit more is into the universities, and intelligence coming in a more timely way, more subtle, because I think they raise them as quite significant with you, but more subtle stuff. That's a good question for the range to probably take into the university, because I couldn't be confident the more subtle stuff actually comes through, but they certainly take part in the Connected to Flow Improve sessions. They've been part of them across the whole hospital in certain areas, and Jane is focusing on students as part of the work that she's doing as well, and doctors in training and SAS doctors, etc. So we're trying to make sure that the Connect is covering different staff groups as well as certain areas.
Thank you very much for the comprehensive work and the details of that. Just as it's a hot topic that was published a few weeks ago by the Royal College of Surgeons about sexual misconduct in females, especially in surgery. Is there any internal audit that's been done from here, and whether there's any link up with the national process in proactively snubbing this?
I didn't, so it was,
you answer and I'll come in after.
I'm not aware of an internal audit, but we've actually done some focused visits within theatres just to hear from theatre staff, and that we are aware that this has come to light. And I've just made some visits there and kind of made my presence known there, just to make sure that they're available to be talking about it. And even if it's because it's come up, it's about encouraging them to be able to speaking in their teams openly about if that's a concern that you have. It would obviously as the staff who are directly involved. So I've done some focus.
We have had insights and feedback in the last couple of years. So what we have done as part of that is this awareness. Has been some focus meetings by our education director of education. We have been to these meetings specifically towards these departments and bringing the national context locally. So there has been a lot of work going behind the scenes, but at the end of it, it's about cultural change.
Yeah, so Andre, what we're doing in this area, so I should have raised it in my report, apologies. So we signed up to the Sexual Safety Charter. I've met with the Chief Registrar as part of the meeting. I met with Katie Adley, Chief Registrar. She's incredibly passionate about it. We've also got a consultant here who's an expert in human factors and has a real passion for this. So I've met with him a few months ago around us having a stronger sexual safety policy. So we'd already started some work on this. On a personal level, I feel really passionate about this. It's a reality of life. And it is something that will, is a real risk within our organisation. So we've looked at, I've spoken to, Tracy's looked at whether there's HCs, I've spoken to the unions to see if anything's been raised with them to look back historically on any learning. And we're just putting together a working group to be taken forward with Chris Burke, the Chief Registrar, with Jane, Tracy and myself. It's an area that we need to, a bit like freedom to speak up, people need to be confident that the boundaries we're setting are really clear and we're not normalising some of this. So, it will have happened to many of us in the room. I'm sure we will have experiences where we felt safe and where we didn't. You kind of take something forward, and we need to create an environment where people do feel able to take it forward and be supported. So it's a nuance of freedom to speak up, but with arguably a lot more of a significant consequence. So so I think this is a really important piece of work around safety more broadly than theatres, but again, so a bit like Councillor Chester, it happened in a certain area. It's a high risk area because of the power kind of dynamic in theatres. So but we want to look at it as a whole hospital. We've linked with the police as well in terms of safety from a broader perspective, so we can update you going forward.
Okay. Thank you very much. coming in place. That's what we want. This is a really important area. For our support. So thank you very much.
Thanks,
Right. What do you want to know?
Thank you, Chair. I'll be brief. So, the paper in the pack outlines the review of the risk and quality assurance framework for food. That includes a number of deep dives. We've deep dived 3 of 4 risks that we hope to during the quarter. The fourth one we haven't got to is the strategy. We've already touched on how we bolster and refresh our efforts around making the other work. At the Legal Committee in Common last week, due to timings, we weren't able to present an updated risk on their insurance framework risk, but the paper in your pack today shows that update, and we secured time at the strategy day for the Legal Committee this month to do some further work on that and review. Only other thing to talk about really is looking forward to the Q3 review. I took a paper to the audit just a few weeks ago to look at how we can connect the output of internal audits that have happened over the last 12 to 18 months back into the board assurance framework, either as identifying control gaps and weaknesses and further actions, or identifying assurance that we can use against controls. And that closes the loop on that particular source of assurance, and we'll continue to build that. So I'm happy to.
Not a question, it's just a compliment Richard report, and to say that there is a really substantial difference in terms of engagement and the ownership of the board level committees in terms of scrutinizing strategic risks. And I would also like to use this opportunity to say thank you for introducing the KPI system, which allows us to measure the effectiveness of our extension system. It was really great to implement. So a lot of these important during the last 12 months. Thank you, Richard.
Thank you.
There's a comment from the committee that just to keep the process that he wants. Thank you. Board of the committee terms of reference.
Yeah, the results of the annual review, the committee's approved some mainly technical changes to its terms of reference, asking the board to ratify them, please.
Thank you. Board composition and appointments to committee.
Thank you, Chair. So 2 items for consideration and approval. One is the prior consideration process to offer a NED role on this board to any interested existing NEDs on the Kettering board. Kettering approved the opposite process yesterday. The second item to approve is to nominate Rachel to the audit committee. We have also, not in the paper, now been able to go out with NHS England for 3 associate NED roles for the Northampton board. That is live now. Rachel has gracefully and happily agreed to have early conversations with interested candidates, and we have already had a number of interested parties seeking to join our board.
People happy with both those. Thank you very much. The enforcement company things. Well, I'm Richard.
Okay, so undertakings. Taking paper as read to briefly introduce, undertakings are a method used by NHS England, previously NHS Improvement or Trust Development Authority for NHS trusts, which is action short of, I suppose, more stringent enforcement action. The undertakings, as you can see, focus solely around developing a financial recovery plan and putting in systems and processes to monitor that financial recovery plan. So in the run-up to today, we've done a lot of work with NHS England to agree on the wording of the undertakings, and that's 2 elements. What are the actual undertakings themselves? And the first element is what's the legal basis for those undertakings. And we've spent some time with them, and they have been to the audit committee to talk about the financial basis and the legal basis of the undertaking. And we've had conversations at the Finance and Performance Committee. Finance and Performance Committee and the Audit Committee recommend to the board that these undertakings are approved and subsequently signed and returned to NHS England. And you'll see in the paper that the Finance and Performance Committee remitted to the CFO to develop that financial recovery plan. And I will work with Richard on systems to ensure that Finance and Performance Committee is cited on progress with that financial recovery plan, and indeed how much detail we should get into in this board on monitoring.
Thank you very much. Any questions from the public? No questions from the public. In that case, I have any other business? Thank you. So the next meeting is Friday, the 8th of December. And we're going to start at 8th Friday prayers. Friday meeting will start at 15. Are there some more minutes, etc.?
Yeah, there are. Post meeting.
Yeah, just before I do that, I'm going to thank Becky for the last meeting. I know they're actually very west of here to Buckingham, Oxford and Berkshire, is it, right? So good luck with that, Becky. But you did considerably, actually. Thank you for everything you've done, and I wish you well.